Hello and warm welcome to this Amgen-sponsored satellite symposium at the ESC Congress 2021, The Digital Experience. I'm Professor Mikhail Kosiborat at St. Luke's Mid-America Heart Institute in Kansas City, United States, and today we will be discussing the topic, 6 years on, what have we learned from real-world use of PCSK9 inhibitors? I am lucky to be joined by distinguished faculty today, Professor Marcello Arca from Spianza University in Rome, Italy, and Professor Kosh Ray of Imperial College in London, United Kingdom. In our three presentations today, we will cover some of the most recent real-world data on the use of PCSK9 inhibitors, including those from the Sweetheart and IFA registries, the Heyman study, and the Gold Registry. We will have a mixture of recorded and live discussions, and I encourage you to use the interactive Q&A options made possible by the digital technology. Now we're going to start, and we'll do that by introducing the first speaker, Professor Marcello Arca, who will be presenting on the European experience with a focus on the IFA and Sweetheart registries. Welcome, Professor Arca.
Good morning. My name is Marcello Arca. I am professor at University of Rome La Sapienza. Several evidence demonstrated that after MI, it's very important to start early lipid-lowering treatments to bring LDL cholesterol down. And this has been further supported by data of Sweetheart registry, where people after MI have been exposed to different statin with different intensity. Some of them experienced LDL cholesterol reduction above 50%. And as you can see in the right part of the slide, those who have the highest reduction in LDL cholesterol show the lowest recurrence of MACE, major cardiovascular events, and all-cause mortality. Another analysis of the Sweetheart study demonstrated that 50% of patients who survived MI and started lipid-lowering therapy needed intensification of LDL cholesterol-lowering treatment using high-intensity statins, additional ezetimibe, and eventually using PCSK9 to reach the target recommended by the ESC-AS guidelines. And so that the conclusion of this first part is that early and large reduction in LDL cholesterol are associated with improvement of cardiovascular outcomes after NMI, and this is more likely to be achieved, this target, through the use of high-intensity LDL cholesterol-lowering treatment, and this can be required a combination of high-intensity statins, PCSK9 in combination. So that the PCSK9 inhibitors can have a critical role in the management of post-MI patient. And let me show you the data of PCSK9 inhibitors used in Italy. We have the possibility to prescribe this medication in secondary prevention in patients who have been challenged for at least 6 months with high-intensity statins plus ezetimibe treatment and still have LDL cholesterol levels above 100 milligram per deciliter. All the data of people who were receiving PCSK9 inhibitors in Italy were collected in a dedicated IFA registry, and then I will go show you the results of a preliminary analysis of this IFA registry. As you can see here, the more than 10,000 people have been included in the registry. Their mean age was around 60. 80% were showing any manifestation of cardiovascular disease. They show the usual pattern of classical cardiovascular risk factors. And more importantly, roughly 50% of them entered into the prescription because they were classified as a statin intolerant. And And the first analysis was dedicated to evaluate the persistence and the adherence. As you can see here, at 6 months, 12 months, and 24 months follow-up, the persistence was very high. At the end of the follow-up, it was above 80%, and the adherence among those who were persistent was still very high. After 24 months of follow-up, the number was running around 90%. And let's show you the data in terms of LDL cholesterol reduction. At baseline, the LDL cholesterol, the mean LDL cholesterol was very, very high, more than 160 milligram per deciliter. And after 6 months, this level was markedly reduced and remained consistent up to the 24 months follow-up. And at the end of this period, the absolute reduction of LDL cholesterol was 95 milligram per deciliter, and this translates into percent reduction of around 60%. And then when we evaluate the attainment of LDL cholesterol target during PCSK9 treatment, as you can see here, at 6, 12, and 20 months follow-up, it remained very high, running around 60%. And in conclusion, patients initiating PCSK9 treatment show markedly elevated LDL cholesterol, despite more than 50% of them were receiving high-intensity lipid-lowering medication. Half of them were considered as statin intolerant. The persistence and adherence was very high, even after 2 years of treatment. Overall, the mean LDL reduction was around 60%, and the proportion of high-risk patients achieving the recommended target was still around 60%. And alirocumab and evolocumab show comparable LDL cholesterol efficacy, even though a larger proportion of patients with high risk required up titration to alirocumab 150 to achieve the recommended target. Thank you for your attention.
Thank you, Professor Arca, for that great presentation. Our next presenter is my good friend, Professor Kosh Ray, who will be presenting the latest data from the Pan-European HAYMAN study. Welcome, Kosh.
Thank you for the introduction. So I'm going to talk about the European experience with the HAYMAN study. But before I do that, I'm going to really provide some context and give you some background. So we talk a lot about dyslipidemia, but what we're interested in is reducing risk. And the first approach to starting or offering any treatment is to assess risk. And this is a reminder of the ESC risk categories: low, moderate, high, and very high risk, and the second category of recurrent events within a 2-year period. And what you can see with these, with this table, is the idea that we don't want to overtreat low-risk individuals, but we also don't want to undertreat very high and high-risk individuals either. So the aim of treatment is first to achieve a 50% reduction in LDL cholesterol for those at high and very high risk, and to recommend specific LDL targets that try and attenuate that residual risk. And between 2016 and 2019, the goals became more intensive in 3 of those categories at moderate, high, and very high risk, meaning that we're recommending lower goals. Now, the approach to LDL reduction, to titrate it, if you will, to level of risk, is shown on this slide. And the idea is that those at highest risk not only achieve a 50% reduction in LDL, but they also achieve an LDL below 1.4 millimoles. Now, we do that by starting with statins, but you can see that in the algorithm, for many, we may need combination therapy, because mathematically, statins alone, by changing the goals to lower goals, may be insufficient. So that starts with first ezetimibe and then the addition of a PCSK9 inhibitor. Now, for context, we also can look at the Da Vinci study conducted in 2017 and 2018, and we can look at the ASCVD patient population. And you can see that in Europe, the vast majority of prescribing is statin-based monotherapy with very little use of combination therapy, whether that's with ezetimibe or a PCSK9 inhibitor. And the dark and the shaded boxes show you goal attainment for 2016 goals and 2019 goals. And you can see in the dark boxes that goal attainment, i.e. achieving an LDL below 1.8, goes up with the potency of the lipid-lowering regimen. But you can see that even with a combination of ezetimibe with a statin, only 21% of people will achieve an LDL below 1.4. So if you add high intensity and statin combo, about 45% to 50% may achieve goals with either of these approaches, but really it's only the addition of a PCSK9 inhibitor that can still really get you to below 1.4. So at the same time, we conducted a real-world observational study, a registry, if you will, the Heyman study, and the countries are shown here, in around 12 countries in Europe. And what this study shows you is the starting level of LDL cholesterol before the initiation of evolocumab. So there's approximately 2,000 patients. And you can see that with treatment, we can achieve almost a 60% reduction in LDL, which is maintained over time. So this really recapitulates the data in the trials. But most importantly, when you look on the right-hand side at goal attainment, and the blue shows you the newer goals, the 1.4 compared to 1.8. And you can see that the vast majority of patients appear to achieve goal, but there's a big difference. So if you basically use evolocumab on a background of some form of oral agent, 67% of patients will get to goal, versus if you use evolocumab as monotherapy, 43%. Now, what is that? So let's look at that in a bit more detail. Well, the main gatekeeper to the use of PCSK9s in Europe is the LDL threshold, which is really not defined by guidelines, but by reimbursement. And you can see these here. And so the net effect of those differential LDL thresholds, the gatekeeper, if you will, for reimbursement, is shown with the crosses. And you can see for the vast majority of countries that the LDL levels before starting evolocumab were much higher than the threshold, as you would expect. And that in turn determines what you can achieve, even with a really powerful therapy that is reducing LDL cholesterol by around 60%. So you can see that even though guidelines recommend an LDL of 1.4, by taking Da Vinci and Heyman side by side and studying, if you like, the bulk of the patients and then the people getting PCSK9 inhibitors, the obvious conclusion is that if the LDL gatekeeper, the thresholds, remain unchanged, then even though we're going to benefit many patients, the bulk of our patients won't benefit, because in order to really achieve goals, you ideally need combination therapy. Therefore, in conclusion, reimbursement, LDL thresholds are the main barrier to guideline achievement. High thresholds basically result in fewer people actually being on a background oral agent and being above that threshold that then enables you to use a PCSK9 inhibitor. And that's a barrier. If we lower those thresholds, more people will be able to effectively receive combination therapy, and therefore more patients will achieve goal. And so in conclusion, really, that reducing the reimbursement threshold is imperative and is the major barrier to guideline implementation and thus improving population health. Thank you for listening.
Well, Kash, thanks so much. That was really a great presentation. And I would like to now discuss the North American experience, and in particular, the findings from the Gold Registry. Well, now we're going to focus on the North American experience in the Gold Registry, and I will start by highlighting something that Kash already mentioned in his presentation, which is the guidelines have been evolving over time in terms of LDL-C targets as more and more data have been emerging from clinical trials. And whether you look at North American guidelines, European guidelines, the targets for LDL-C cholesterol management in patients with ASCVD have been getting lower and lower over time. And the question is, of course, what we're trying to ask and answer in these registries and real-world data is that translating into clinical practice? So we try to do this in North America from the data in the Gold Registry. This was a large registry in the US of over 5,000 patients and nearly 120 sites. And you can appreciate that, as you could expect in the ASCVD population, the patients were older, about 60% were men, and everyone had ASCVD, but majority of patients had coronary disease, and about 80%, with about a third having prior MI, a third having diabetes, and a third having family history of premature atherosclerotic cardiovascular disease. So let's take a look at the data, and we'll start by evaluating the LDL cholesterol levels over time. The patients in this registry were divided into three cohorts: the PCSK9 inhibitor cohort, and those with LDL-C between 70 and 99 and 100 or more milligrams per deciliter. Overall, I think one of the interesting findings here in this recent publication in JAMA Cardiology is that the LDL-C levels were relatively constant over time. There was a modest decline in LDL-C levels in the cohort of patients that had cholesterol levels, LDL-C cholesterol levels, at baseline of 100 or more milligrams per deciliter, but that decline was quite modest, and there was little change in other two cohorts. As one would expect, the lowest LDL-C levels were observed in the PCSK9 inhibitor cohort. There was also little change over time, despite guideline recommendations and despite clinical trial data in the statin use over time, especially when it comes to high-intensity statins. You can appreciate very little changed. There was also very little increase in ezetimibe use in combination with statins, PCSK9 inhibitor use, or use of intensive lipid-lowering therapy overall. Speaking of changes in treatment over time, despite the fact that everyone had ASCVD and overwhelming majority did not have well-controlled LDL-C at baseline, only about 1 in 5 patients underwent intensification of treatment over time. While patients that arguably had the highest need, those with LDL-C of 100 milligrams per deciliter or higher at baseline, even in that patient group, again, just 22% actually underwent intensification of treatment. And importantly, just under 10% of patients actually concomitantly had de-escalation of treatment, again, despite a really huge need in this population for more aggressive LDL-C management. And that, of course, translates ultimately into LDL-C goal achievement over time. And you can appreciate in the summary that very, very few patients, less than 7%, actually had LDL-C less than 70 milligrams per deciliter at baseline. And even fewer had LDL-C less than 55 milligrams per deciliter at baseline. That number of patients achieving goal of less than 70 milligrams per deciliter increased to about 32% at 2 years, but still more than 2/3 of patients were not achieving that target, despite a great need because of background ASCVD and the fact that many of them had multiple risk factors and were very high-risk patients. Now, when you look at which populations of patients or subgroups of patients were most likely to achieve that target of less than 70, those are treated with PCSK9 inhibitors and other combination therapy with either statin or ezetimibe at year 2. And unfortunately, the group, again, arguably with the highest need, because the LDL-C cholesterol was 100 milligram per deciliter or more at baseline, that was the group that actually was the least likely to achieve LDL-C target of less than 70 milligrams per deciliter at 2 years. Very similar trends were observed if you use the European target of less than 55 milligrams per deciliter. What about some of the really high-risk groups like those with a prior history of myocardial infarction? We see very similar trends here. Less than half of those patients were receiving high-intensity statins, and even in patients that had an MI within the past year, close to 40% were not receiving high-intensity statins. And if you look at optimal medical therapy that encompasses other guideline-recommended treatments, about 2/3 of patients, regardless of when the MI occurred, were not receiving that guideline-directed therapy. And a very similar picture was actually observed in other high-risk groups, including those with a combination of ASCVD and type 2 diabetes, where majority of patients were not receiving high-intensity statins, and less than 7% actually receiving optimal guideline-directed therapy. So in conclusion, what we observed in the Gold Registry is in about 5,000 patients with ASCVD, majority were not on high-intensity statins, and less than 7% had LDL-C levels below 70 milligrams per deciliter at baseline. Over a 2-year follow-up, despite emerging clinical trial data and evolution of practice guidelines recommending lower LDL-C targets, only about 17% had intensification of treatment over 2 years of follow-up. 2/3 did not achieve LDL-C target of less than 70 milligrams per deciliter, and situation was a bit better in patients that were on PCSK9 inhibitors, where just over half of patients achieved that target, and less than 15% of patients achieved LDL-C target of less than 55 milligram per deciliter, again, with that number being about 40% in patients in the PCSK9 inhibitor cohort. The findings were very consistent even in those subgroups of patients who are at very high risk, such as those with recent myocardial infarction, type 2 diabetes, polyvascular disease, and other high-risk subgroups. Overall, these findings identify a large implementation gap and highlight a clear opportunity for improving quality of care and outcomes. Thank you. We now have the opportunity to have a live virtual discussion where we can further have a conversation about the clinical implications of this data and address your questions. Great. Well, Kash, Marcelo, as always, thanks for a fantastic session. And we now have an opportunity to entertain some questions and have a discussion. We already have a number of questions from the audience, but I'll start by asking both of you, I think, a fundamental question from all of our presentations that we had today. I think one clear message that emerges is that still now, God, how many years or decades after the evidence started emerging that lower is better, we're still at the point where a large proportion of patients that really could benefit from aggressive LDL lowering are not getting to the treatment goal. And of course, cost gets blamed frequently. We'll come back to that. But many of the interventions we can have nowadays are actually very inexpensive, and in many cases don't cost anything to the patient or very little. And still, we don't get to the target in the majority of vulnerable patients. So is it really the systems of care that need to change? And Kash, maybe I'll start with you and see what your thoughts are on this.
I think there are multiple problems. Thanks, Mikhail, for the question. I think there are multiple problems. The first is we actually do ourselves a disservice by thinking about these treatments as treatments for dyslipidemia, hypercholesterolemia, and words like that are used when these drugs are made available. The business we're in is reducing risk. Whatever your risk is, the more you lower LDL, the lower you're going to reduce risk. Now, if you start with that argument, then we have a risk-based approach. And then it becomes much simpler. The higher your risk, the more aggressive we need to control that cholesterol, which may not be that high, but actually what we need to do is drive it down because you already had heart disease. And then we need to take out this stepwise approach, start to talk about intensive lipid lowering, starting with statins and ezetimibe, and then pick up the outliers maybe with more expensive treatments.
Yeah, and there was actually, yes, Marcelo, please go ahead.
Yeah, I would like to add some consideration to what Kash said. I think that as a doctor, we don't have to worry to bring the cholesterol too much down, okay? Because I think one of the limitation of in producing some kind of clinical inertia is because many doctors are worried about to bring the cholesterol, LDL cholesterol, too much down. So that the data are really reassuring that if you bring the LDL cholesterol down to, let's say, 30 milligram per deciliter, you don't produce any harm to your patient. This is an important thing to keep in mind.
Yeah, the lower the better. Sometimes what I tell my patients that already have established disease is that there is no LDL that's low enough. And that, I think, is the bottom line message. Also to both of you, one of the questions that is getting some votes here is, what do you do with a patient who appears to have reasonably well-controlled LDL? So the question doesn't give a number, but let's say somewhere around 70 milligrams per deciliter, let's say, Kash, at baseline, and the patient's progressing and having recurrent events. What would be a strategy and a target for a patient like that?
I mean, somebody like that by ESC guidelines would have an LDL recommended of below 1 millimole, so below 39 mg per deciliter. So that would be the goal, because this is somebody who is vulnerable even to that level of LDL cholesterol. And that 1 millimole reduction would reduce that person's relative risk by at least 1/5 over 5 years. And in absolute terms, probably much, much more, because the 10-year risk is probably more like 30% or more.
Right, and a related question actually to that is, what would you do in somebody who had an acute coronary syndrome? Would you consider studying a PCSK9 inhibitor up front, or would you wait and see what happens with statins and perhaps statins and ezetimibe?
I mean, I think, yeah, Marcello, please.
Yeah, it depends. I mean, the guidelines suggest to consider the possibility to use PCSK9 inhibitors also during the hospitalization, just to try to get as faster as possible the LDL target. In my practice, I would consider the background therapy, so that if this patient develop a myocardial infarction or ACS, despite the background therapy and the lipid-lowering background therapy, I would immediately think to improve the control LDL cholesterol, for example, adding an additional treatment like PCSK9 inhibitors.
Yeah, so there are a couple of questions that I'll handle very briefly. One asks about the dosing of PCSK9 inhibitors in patients with heart failure or kidney failure. The simple answer is you don't need to worry about heart failure or kidney failure. The dose is the same. And then the second one asks about PCSK9 inhibitors and diabetes risk, and that's simple as well. There is no increased diabetes risk with PCSK9 inhibitors.
Yeah.
Okay, there are a couple of questions that have to do with cost considerations and reimbursement, especially in Europe. So both of you are much better positioned than I am to answer that question. So Marcello, maybe very briefly, what's the situation in Italy, and then Kosh, what about UK?
I mean, in Italy, we have a quite good situation, because if I have a patient who are already an MI, and I want to start the medication, I mean, PCSK9 medication, I have to consider, of course, the LDL cholesterol level, and also the previous treatment. And according to the new guidelines issued by our regulatory agency, apparently we can start a PCSK9 if the LDL cholesterol is above 70 milligram per deciliter after a very short time observation with background therapy. So that we are going to have a better recommendation, to improve the care of our patient.
Yeah, and in the UK, we've got NICE, and our threshold is 3.5 millimoles for people with recurrent or multiple manifestations of cardiovascular disease. Single manifestation, 4 millimoles. FH primary prevention is 5 millimoles. Now, when these were done, it was thought to be cost effective, and they thought many people would be on this. But the issue that we've had in our country is that basically this is secondary care initiated. So a whole bunch of the patients that in primary care don't get referred in. And now the NHS accelerated collaboratives, and these people are desperately trying to find these people and get them referred in so they can get the treatments, because if they're above that threshold, they will be reimbursed. But I think, as I showed, the biggest determinant is that LDL threshold. So you're forcing people to effectively be statin intolerant to get above it. So effectively, in much of Europe, you're using MABs as monotherapy. Even a drug as powerful as a MAB, when you start sufficiently north of 55 mg per deciliter, so if you're above 110, 120, monotherapy is only going to get a certain proportion to goal. So that's one of the challenges that we have.
Yeah, so to that point, caution, this is rapid fire now. We've got about a minute left. So we have our targets and the guidelines. Should we think about just default combination therapy in a lot more of our patients than what we've been doing so far with the step-up therapy that we used to?
Yeah, drop the ezetimibe step. Everybody gets statin and ezetimibe. You're not at whatever goal for level of risk if you go on to a MAB or other treatments.
Yep. I totally agree with Akash.
Yeah, and last question, how long does it take for someone to see the effects of PCSK9 inhibitors on LDL? Very rapidly, 15 seconds.
Within 7 days, you're basically getting it.
Yeah.
Okay, terrific. Thanks very much. Always a pleasure, Kash, Marcelo. I would like to thank our audience for participating and wish you a enjoyable Congress. Be well, stay safe, and please stay on for the closing. Well, thanks very much, everybody. And in closing, I would like to invite you to another symposium to be held on Monday at 7 p.m. on a topic of the most appropriate time to initiate PCSK9 inhibitors in acute coronary syndrome. The symposium is titled LDL-C Management in Acute Coronary Syndrome, Time to Act, and will be chaired by Professor Derek Connolly from the Birmingham City Hospital in Birmingham, United Kingdom. Thank you very much and enjoy the Congress.